Hi, good evening to everyone. Thank you very much for joining us. This is an important conversation, and it is an extension of a conversation that I started easily in April of 2023, where I discussed with Tom Haviland about his research on Embalmers Clots. I then had another discussion with him in January about more recent up to date research. And then what happened is that someone reached out to me anonymously to share what they saw was happening in the live people. I then did an interview with that just about a week ago. That's on Substack. I'm not sure if you'd be able to see it on any other media channel. And that has done exploded the interest in these query embalmers clots. The important thing, though, is that I'm interested in the science. If it is occurring, I want to understand why. What is the mechanism? Is it different from normal? Is there anything that we have to be concerned about? Is this something that needs a change in the way that we apply our medical practice? Do we need to use stronger anticoagulation for longer periods of time? Do we need to combine it with antiplatelets? There are all kinds of clinical questions that come out of this kind of observation. I think the big worry is that the scientific community has watched this overall generally for some time. But there are some scientists across the world who are focused on this and they are looking at it. And today I have the pleasure of speaking with two of them. We've got Professor Resia Pretorius from South Africa, and we've got Dr. Robin Rose from the USA, who's been looking at microclots. And Robin, you can unmute yourself. But let's start off with Resia. Do you mind just giving a quick introduction of yourself?
Yes, hi, thank you, Philip. This is an exciting live. I'm Resia Pretorius. I'm from Stellenbosch University in South Africa. I've been looking at clotting pathologies in various diseases for many, many years. They include cardiovascular disease, diabetes, Parkinson's, Alzheimer's, rheumatoid arthritis, and I've been studying platelets and red blood cells, as well as the clotting protein fibrinogen, which is supposed to be the soluble clotting protein. And in 2020, I turned my attention to acute COVID and later in the year, long COVID.
Excellent. And Robin?
Hi, I'm so glad to be with everybody. Thanks for having me. I'm Dr. Robin Rose, and I'm double board certified in gastroenterology, internal medicine, but I've been practicing functional integrated medicine for the last 4 years, and I got involved with long COVID about 3 years ago. And I've been in various research groups, and I've been carrying out a lot of the bench research and the research that's being done in the clinical clinical arena. So I'm really happy to be here, and I've been, very focused on the microthrombi, microclotting as well. So I'm excited to have this conversation.
Excellent. So let me just let the audience know something. Sadly, I'll not be showing any live clots because it can be a bit gory for people. But I had just prior to the live shown both Robin and Risha the clots that had been shared with me. Do you mind sharing what your thoughts were? These were clots from live embolectomies where they're pulling out clots of live people. So these are not embalmers clots. These are clots that are pulled out of live people. What were your thoughts?
Resia, you can go first. Go ahead.
Okay, I was quite shocked to see the size of the clots that was found in live people. Obviously, those are not microclots anymore. They are definitely macroclots. And I absolutely cannot believe that a person can even survive or can even be alive with those type of macroclots pulled out of them. So I was quite shocked.
And Robin?
Yeah, I can echo exactly what Resia just said. I can't believe what's so unbelievable to me is how it actually takes the formation of the vessel, of that blood vessel it's in, and such a wide circumference and length. They're massive, and it's harrowing. I can't believe people are able to walk around like this as well. It's very shocking, and the fact that the body cannot degrade these is very frightening. And it's something that we really have to take a close look at.
Yeah, one of the things that he had said from the cath lab, he said that they normally what we'll do is thrombolysis, and they'll use intra-arterial thrombolysis for some of these clots before they try and do the embolectomies. And I got the impression that they weren't breaking down even with intra-arterial thrombolysis. So this is some pretty significant stuff. And so when I started to reflect, I would be waking up in the morning thinking about what the heck is the mechanism for this. And truthfully, Risha, what happened is that just a few days ago, so I appreciate you coming on at short notice, I thought to myself, if there's anybody who is going to be able to try and explain the science behind this, it is you. So can you give us a little bit more background into the specific focus you had been on with regards to the microclots? And I've got here, I'll show you your paper here. So this is the paper that you had done. This was in 2022 with Professor Kell. I had a chance to chat with him as well, but I'll have to share that conversation at another time. But this paper here was looking specifically at these amyloid fibrin microclots. Do you want to tell us a little bit about the background as to, because you guys identified this from as early as 2020?
Absolutely. So in 2020, when we were right in the middle of the pandemic, I worked together with a clinician that was seeing acute COVID patients, and he was in the ICU of one of our private clinics. And I've worked together with him previously because he's a specialist focusing on diabetes. So I got our first samples already in 2020. In the past, so years before 2020, my research focused on fibrinogen, as I mentioned previously, but we were interested in how the fibrinogen, which is the soluble plasma protein in all our circulation, in the presence of thrombin, which is the end stage of the clotting cascade, how does those fibrin networks look like? So that was my focus previously. So I always took whole blood or platelet poor plasma, and I added thrombin to create in the lab to mimic the clotting cascade. But in the thick of things in 2020, I couldn't get thrombin. So I was just thinking, how can I just look at what's in these plasma from these patients, where my clinical collaborator mentioned that they suffered from severe clotting pathology. And I just added my marker for clotting pathology, or amyloid clots, or amyloid clotting, which is theophlavin T, a well-known marker. I just added it to the plasma, and I looked under the microscope without thrombin. So I wasn't expecting anything. I was thinking, well, let me see what I get. And to my surprise, it lit up like Christmas trees. And then I realized that in acute COVID, these clots were forming spontaneously without the addition of thrombin in my lab. So these microclots, we used the term later. We called them amyloid clot formations. Were actually present in the blood as it comes out of the patient. So that was quite interesting for us. And then a few years later, a year or so later, we looked closely at spike protein to see if we could induce the same clots in healthy blood, which we had in our lab, if we could induce them in using spike protein. And then end of 2020, beginning 2021, we realized that long COVID is a thing. It was just starting to be a buzzword for everyone, with the Perego group identifying the term long COVID. And then finding patients with long COVID and seeing that they looked exactly the same as with the samples that we found in acute COVID. So that sparked off the various research papers, and the one that you showed is a review paper where we looked closely at what are the characteristics of these microclots and why might they be dangerous for individuals that suffer from them.
And so just so people have an idea of the science, so this is from the paper, and you had in there the formation of the formation of the clots, the fibrin clots here, and then the breakdown of it with plasmin as well. So this here represents, is this the, what is this at the top? This is just fibrinogen, soluble fibrinogen. It then makes the clot with platelets, and then when the body needs to break it down, that's where the plasmin comes in, breaks it down, and then you get the D-dimer at the bottom that we can measure. So this is the cascade. Now, these clots, what I'm trying to understand, when they make these clots, what is it that is different with regards to the amyloid bit? Is it that amyloid gets caught up in these clots? What is it?
So the scheme that you are showing on the screen now, the top is the soluble fibrinogen. So I must just perhaps say, so that everyone understands it, perhaps do not know the clotting cascade. We have got, every one of us have got soluble fibrinogen in circulation. Then when you cut yourself, the action of the collagen that's exposed in your skin, for if you cut yourself on your hand, the process of the cut will get all the platelets to rush in to form a block. Then the next steps will be soluble fibrinogen will be converted to fibrin nets by a cascade process. But then after the wound heals, then there must be a process called fibrinolysis, so that the little clot, the little scar is healed, and then the scab must be broken up. This can also happen in your vessels. It's a normal process. So someone with plaque formation inside their blood vessels, there might be little tears. And so this process can also happen when collagen is exposed, soluble fibrinogen is converted to a little fibrin net, and then it's broken down. So that is a normal process. The difference between if we have inflammatory markers in circulation, and in the case of COVID, we've got lots of inflammatory markers, but the distinguishing factor is in acute COVID, you have got spike protein also in circulation. So if you've got your soluble fibrinogen marker and you've got spike protein and all the other inflammatory markers in circulation, they bind or can bind to the soluble fibrinogen protein in a direct protein-protein interaction. And that causes the soluble fibrin structure to untwist into, we say, beta sheets, which is an amyloid structure. So the binding of the circulating inflammatory molecules onto the soluble fibrinogen causes it to change, and it folds into a insoluble little microclot. And many of these microclots can join up to each other. And as I like to describe it by saying that these microclots are little dustbins. They roll over the endothelial layers inside of your vessels. They roll over these endothelial layers, and they just hold like a little dustbin of everything that comes along. It might be antibodies, might be pieces of endothelial cells, it might be inflammatory molecules in circulation. And entrapped inside these microclots are then the various inflammatory molecules. And we have then in 2021, we did proteomics, and we broke open these microclots and we made them soluble again, their content soluble. And we found a lot of things inside it. But one particular was of interest, and that was the fact that they contain alpha-2 antiplasmin. And that molecule prevents the microclots from breaking down. So it's a whole process, and we must remember that COVID is a new disease. Long COVID is a new disease. So we don't have all the answers yet, but we are slowly trying to understand and build on what we know, on what is happening, how the process forms. And the bottom line is that in acute COVID, there's widespread endothelial damage that cause widespread damage to the layers of the endothelial, the inside layers of the vasculature. The microclots are formed, but there are also other things happening. There are also platelets that's being hyperactivated. So I've been mentioning spike protein and the various inflammatory molecules in circulation. In the case of cells like platelets, Platelets have got receptors on their membranes, hundreds of receptors, thousands of receptors on their membranes. They can interact with a lock and key process with inflammatory molecules, also with spike protein. When that happens, the platelet also hyperactivates. So now in acute COVID and also in long COVID, we see platelets are significantly hyperactivated. Microclots are formed and endothelial damage are present. And other people have also said and shown that endothelial damage are significant in acute COVID, but also in long COVID. The endothelial layers are broken and damaged, and that might be, I think, mostly due to spike protein. So it's a new disease, a new mechanism that we must study.
So let me ask you from a practical clinical point of view, Robin, because you are looking at the patients in clinic from the perspective of these microclots, because this is what I am thinking is occurring. Microclots are becoming macroclots in some people. So in order to get the macroclots, you first need to have the microclots. What are you seeing in clinical work with regards to these microclots?
So we're doing the testing, and I was saying to Resia before, many of the patients that have presumed long COVID or what we call spike injury that might not even be so asymptomatic, but they're inflammatory biomarkers, and a lot of the different advanced biomarkers we're looking at are abnormal. They're scoring a 3 out of 4 to a 4 out of 4 on this microthrombi testing. And so that gives us cause for concern. And then we're correlating that with certain biomarkers, like, extremely elevated TGF beta 1s. A lot of people have elevated D-dimer. Some people don't, which I would love to actually ask Resia about, because there has to be some part of the clot that is breaking down, right? That you're getting the D-dimer or seeing it sometimes in these people, like you're capturing it, right? It depends like when you're doing their blood work, right? Because one day maybe you're getting some and one day you're not. But it seems to correlate. And, I feel like it's a really, really good diagnostic biomarker to follow these, because, we would like to see, like Resia was saying, them to be more like a 0, 1, or 2 versus a 3 or 4. I guess the other thing too is it would be nice to be able to qualify the clots, right? Because if it's truly a clot, a microclot, like Professor Pretorius is referring to, then from the spike protein and from long COVID, then those are not going to break down, versus maybe other clots because maybe some things are being conflated, right, clinically. So it would be great to be able to figure out a way to be able to tell, like, what type of microclot is this maybe in the future as well, so we can really identify those patients and, make different buckets to help.
So when we think about what, say, for instance, because part of the question is around, I am not ignoring what the embalmers are seeing. I can't explain it, but we're seeing them, some of them at least are saying they're pulling out these massive fibrous clots that sound like what you're saying, Resia. It's an amalgamation of amyloid, and they're therefore forming these insoluble beta sheets. Now, I had always thought this was post-mortem. So microclots, yes, I could understand it occur, but the big clots would occur post-mortem. I just couldn't believe that it could occur ante-mortem. So when I saw the clots from the catheter lab, I realized, okay, this is now something that may also be occurring in the living. So when we think about, if you imagine someone with stage 4, because you were mentioning 1, 2, 3, 4 stages. Stage 4 is where you have the highest number of clots. And I think there's an image from your paper. I'm just trying to see if I can find it, where it shows the clots. I think it's right here. So here is showing, this is normal. This is stage 2 and B. This is stage 3, and this is stage 4. Is that about right?
No. So A is what you would find in a healthy individual. B, C, and D is stage 4.
Okay.
So that's quite significant microclot formation. B is a very large one.
So this is now becoming a macroclot almost.
It's still.
And so can you?
That, right?
Yeah. So what I'm trying to understand is, because from a clinical point of view, if this was occurring and quite significant, we would pick this up on an angiogram. But angiograms are not really seeing these big clots floating around. If anything, it could look like plaque disease, where you can see what you think is an atheroma. Do you think that this kind of macroclot becoming attached to the endothelial lining of a cell could then be amyloid? We wouldn't be able to know, would we?
So in our minds, all of those that you show there are still microclots.
Hmm.
The green signal is the amyloid structure of the microclot. And if you look at the B photo that you showed, if you look at that, it seems to be, if it's quite a fluffy, a pliable structure. And that's, we don't fully understand it. There is a recent paper, Philip, that I shared with you a few minutes ago, about the chemists who actually look at the tomographic mapping of the clots. So perhaps they would, if they, with their methods, could look a little bit further, they might distinguish different groups of clots. So the issues, those, the B version that you showed of a clot, of a microclot, can push through and squeeze through small capillaries. And it's interesting also that those clots do not seem to functionally block the vessels, the microcapillaries, fully. It might block it temporarily or prevent blood flow as it should, and prevent oxygen transport over the endothelial layers, which are also damaged. So I can really comment on the structure of the microclots, but I think the issue that that's quite scary for me and is actually very interesting is the structures of the significant macroclots that are pulled out from healthy individuals. And I think entrapped in these macroclots are a lot of these microclots, and it might have started with that. So the question that I pose myself is it the same process? So we will not understand the structure of those macroclots pulled out before we test it with an amyloid marker. But I will not be surprised if it is amyloid, because the nature of a fibrinoid microclot is that it's an insoluble little entity that has changed structure, and it will not go back to an insoluble form except if you break it down. Now, Robin mentioned D-dimer. That's very interesting for us. D-dimer was never found for us to be a good marker for long COVID. It's an excellent marker for acute COVID. But in long COVID, we seem not to be finding D-dimer in the very sick individuals without treatment. If we look at D-dimer. Now, the explanation that we have is D-dimer is a breakdown product of fibrinolysis. So if the clots are not breaking down as they should, so the fibrinolytic process is a failed fibrinolytic process or clot breakdown process, D-dimer will not be a good marker. However, we have been, or our clinical collaborator have been finding in South Africa, Dr. Jacobus Laubscher, if he treats the patients with anticoagulation, when the clots start breaking down, D-dimer goes up. And that's also been noted by a few clinicians that I've spoken with. If they are treating patients with anticoagulation, D-dimer is a good marker, because you would expect it, because the clot will be breaking down with the anticoagulation.
So I wanted to ask Robin something, just thinking about because all of this is us trying to understand and speculate. In order for someone to have a significant, let's just say a moment, let's just assume they are amyloid based. And if they were to have an embolus, it would suggest that this is gradually building over time. But as I said, we can't see it. An interesting thing that Dr. Shetty said when he was with me when I was speaking to the whistleblower, he says it's almost as if it could make a cast on the inside of the blood vessel. Does that clinically make sense to you?
Yeah. Yes, absolutely. And I also think that the glycocalyx layer plays a role in stabilizing the glycocalyx. But how can you even stabilize the glycocalyx if you have this? It's like you have to rid the body first of the spike protein, get to the root cause, and then treat it. Otherwise, that's what's so confusing. Otherwise, you could be adding fuel to the fire, right? Depending on how you approach it. I did want to go back to the D-dimer because I think this is interesting. Because so what we did, Resia, we just added it to our panel for anyone walking through our door. And I would say 50% or more of the patients walking through our door have an elevated D-dimer. They have an elevated D-dimer. It's unbelievable. And so I wonder, and I would love to get your opinion, if there's sort of like a mix, like at the beginning when the clot starts before it forms the beta out, like maybe that's when you're capturing them, right? Or if you're getting some sort of breakdown, if it's like a mixed clot almost, right? And then it's transitioning to this fully insoluble clot. I don't know how you feel about that, but maybe that's what we're seeing too, or possibly because we're seeing this all the time. And it is mind-boggling, right? Because prior to the pandemic, you shouldn't have an elevated D-dimer. I mean, unless you're having a P or a D.
Exactly. So I fully agree with what you say. It is exactly what I'm also interested in, and we need to talk about that. We don't know exactly how it will work. And interestingly, also one must remember that even if you have got severe long COVID with microclots everywhere in your body, in your system, your body's, although we say you have a failed fibrinolytic system, it's not a critically failed fibrinolytic system because you are alive. If you are alive, your fibrinolytic system will work, but the failure is a pathology of the process. So hopefully your body will have some way to slower but still break down clot. Otherwise, you will end up being dead if the failure is critical. So perhaps in the individuals where you do see D-dimer, their body is still trying to break it down.
Right.
So it would actually be very interesting, Philip, if one can understand the blood work of the individuals that these macroclots have been pulled out. What does their blood work tell us? How does their D-dimer look like? And the other inflammatory panels? That would be very interesting for me.
I think one of the problems we have is that if you think about it, this is probably one of the first pure scientific discussions about this observation that has been going on for a few years, and so therefore the kind of work that needs to be done is only just going to be started. What I'm worried about is that it seems that the scientific community, other than a few people, because Resia, you were saying you guys have been working at this for some time, but there is a paralysis of the scientific community in terms of getting this, because I am sure that if we checked in different cath labs across the world, this is likely to be something everybody is seeing, but nobody is talking about. How do we fix that? Because this is what I'm saying, is that I just assumed this could not have been happening and pre-mortem, because I thought if it was happening, we would hear. Any thoughts on that?
Yeah. I'm just shocked that how could it only be isolated to one cath lab? That you're right. It doesn't make any sense. So how are people not wanting to investigate this or understand this more and figure out, how to prevent it, right? And be proactive about this. It's just shocking to me. I mean, Resia, have you heard this in South Africa from any clinicians or cardiologists that do casts there, or no?
No, I haven't. I have not. This is the first. I obviously know about the post-mortem clots that have been pulled out, but definitely not in healthy individuals. It would be interesting to ask them, because obviously perhaps they've seen it, but they haven't reported it. So it would be interesting to Philip, if one could have a discussion with people that typically pull out these type of clots from.
I guess one of the things is that, one, you would have to have a suspicion, because how would you differentiate it macroscopically from a plaque, which would also give a yellowish whitish appearance? And so I suspect that if people are doing vascular surgery, they're pulling out clots, they're not actually examining the clots. They're more concerned with actually stopping the bleeding. So once you pull out a clot, you just discard it, unless it needs to go for histology, which most clots wouldn't need to go for any kind of further investigation. And so it requires, I think, a degree of suspicion. So meaning that if you have no suspicion that this is occurring, you wouldn't even think to look at it, and you may easily overlook something that, yes, in retrospect, you go, actually, yes, I do think it has looked different, but I didn't make anything of it. I just didn't think about it, hadn't heard anybody. So this is part of the raising awareness, in that I'm pushing the question now to everybody who is doing these procedures. Take a look at these clots, because if this is a pattern where we're pulling out big clots that can't be easily, and what the whistleblower said is that literally it's like an elastic band. You just can't break it. It's physically, not hard, but it's very fibrous, a bit stretchy. And so therefore there is no way that fibrinolysis therefore would be able to break it down.
But I have a question. Do these doctors, vascular surgeons, cardiologists, prior to the pandemic, prior to exposure to the S1 spike protein, did they see clots this massive and big? And is this that's what, right? Or is it just that it's only the quality of the clot that's changed, not actually what it looks like?
I think it's not necessarily, I think it is a combination of both. Size and the characteristics, the physical characteristics seems to have changed. And that's significant, because what it suggests is that these are happening, and we don't know that it's happening. And the question would be, clinically, what tests could we then use to try and identify who would be most at risk? Now, the only thing that Resia says that I don't quite agree with, which is that healthy individuals, clearly all the individuals are sick, meaning that there is something happening that has predisposed them to having some kind of either clot in the leg or clot in the lung and so on. And they may have some endothelial inflammation. One other thought I want to throw out here. We have to deal with the source of spike protein. I can completely agree that infection, spike protein can do it. The other thing that we're seeing is persistent infection in certain cohorts where they're not able to clear the virus. And so therefore ongoing circulation of the virus could therefore trigger this. But the elephant in the room, as I say, is around the fact of extraneous sources of spike protein from other activities. My view is any source of spike protein could therefore theoretically be a problem. And your work had shown, Resia, that just adding spike protein to the plasma drives these microclots. Isn't that right?
Absolutely, yes, that's true. And we are just completing a study in South Africa where we looked at a combination of long COVID patients where they have long COVID due to acute infection, but also to a cohort of individuals who had vaccine injury. And now I must really say how difficult it is to say a person has had only vaccine injury, because we know many people had perhaps an infection, acute infection, but they were not symptomatic. So it's very, very difficult to decide who is a pure vaccine injury individual. So I must say that's very difficult, and probably we will never know. But what we have been seeing in the cohort that we have been looking at, who clearly said they had an event like pericarditis or a significant event after the vaccine, we do see microclots in those individuals too. So our study would probably be ready in a few months to confirm, and with stats and all the things that we need to do with that. But for sure, the spike protein, I think, Philip, you are right. It can come from various sources, and one source possibly could be from vaccination. And we do know that they have been reports by many people previously that there are vaccine injury, and it is a term that we need to discuss, and it is an elephant in the room, because obviously we would want to not discourage people to have vaccination because it might save lives, and it has saved millions of lives. But what we don't know is who are more vulnerable to vaccination, and that we need to figure out before the individuals take a vaccine. And that I don't think we have figured out yet. But spike protein, I believe, is central, whether it's from the acute phase or vaccination. I think both might play a role.
Yeah. I'll share a thought, and then I'll ask your thought on it, Robin. Not a thought. Very early on in 2021, the Israelis noticed a pattern that I thought was very important, which is what we call hypermetabolic lymphadenopathy. So they found the patients that they were going to look for cancer in, if they had been vaccinated within 3 months of the PET scan, they couldn't tell if this was cancer related increased uptake or if it was from the vaccine. So they then did a study on it, and they found different stages or different grades of hypermetabolic lymphadenopathy. So the lymph nodes are taken up. What struck me was that over 25 days, we're talking about 3% of their cohort still had ongoing lymph node inflammation, which is not supposed to happen. I am thinking that could this be a source, therefore, for ongoing exosome transfer of spike proteins, which could then lead to a combination? I'm just, as I said, there's got to be a source of spike somewhere in order for it to continue to make or trigger this kind of coagulation. Any thought on that?
No, I agree with you. And there's lots of papers that show transfection of the spike, transfection of the spike protein, whether, from having the vaccine as well. I mean, that's been shown. And Carla Bronia, back in, I think it was August or September this past year, he published his results showing that over 50% of he had vaccinated patients, and he showed over 50% of them at 187 days still had circulating spike protein in the blood circulation. So, right. So what do we do with that? Like there's a source, right? And we know that spike protein, whether it's from the virus or the vaccine, is a magnet for every cell. Like every cell that it comes near or comes in contact with, it's a magnet, and it will get taken up. And then how does that then translate into clinical disease or not? And so we really need to be looking at all of these things. And like, Resia said, I agree, like, the vaccine has been shown to help people and so on and so forth. But we need to identify those individuals who are at risk for this, and that we're, doing more harm than good, right? Like any intervention in medicine that we give, you always have the risk benefits and alternatives, right? And we need to explore those things and make sure that we're doing right, by certain people and not wrong, or vice versa. So this is a very important thing that we need to look at for sure.
So this conversation, because I know we have to wrap up, Robin, time is running out, so we're going to just wrap up. But this is just an initial conversation, and I'm sure I'm going to be talking with Resia again. But this is a test run for us to think out as to what the mechanisms could be. But people watching may be asking, what can I do if I'm worried about this, or if somebody or relative has had clots, or they're, if people are worried, just outside the box, any thoughts from both of you before we close? Resia, you want to go first on that?
I think that is a very difficult question that you ask, because most importantly, we need to get diagnostics, not only microscopy, but also flow cytometry. We've developed an imaging flow cytometry method. We are working closely with pathology labs all over the world to get the diagnostic in regular pathology labs. That's the first thing. If we don't have diagnostics, we can do very little, because you can't really tell people now to go on any medication if we're not testing, because people can start bleeding. So the number one thing for me, and we're working really very hard to get more people interested, to get more pathologists interested to run these type of tests. So diagnostics are crucial. Without that, treatment cannot be initiated, because what are you treating if you don't know? So Robin and what she's been doing, that's absolutely fantastic, because we need open-minded clinicians that take responsibility for patients, and not only, you need to think out of the box. It's a new disease, and we need people like Robin. If there aren't clinicians like Robin, I don't know how people are going to survive. So it's just a big thank you, Robin. You are really, it's wonderful what you do.
Thank you. Ditto. What you're doing is unbelievable too. I would say, I just wanted to go back to the microclot for 1 second too. It's not just what's happening even clinically, or what's happening from a clinical, from what people are manifesting even, or how they're feeling. I'm worried about all the studies showing that there's damage, to the brain, all these things coming out, like showing that there's decreased blood flow, that you have vascular inflammation, neuroinflammation, that then will lead to neurodegeneration and all these things. That microclotting is definitely playing a role here for sure. And again, it all goes back to this endothelial damage, endotheliitis, and this ripple effect of how it's going to affect all of these people moving forward. So, Risia's right. We have to get these diagnostics in place. We have to start recognizing these things so we can be more proactive instead of reactive, and really, help as many people as we can. But what was the question? There was something else I felt like
it was just, what can people do?
That was what I wanted to say. So my research group too, we've developed, we take more of the approach. We use natural compounds, and we've been able to show reversal of the clotting using that, and then that sort of takes away that risk of bleeding and being more complicated, because and obviously, like, you have to have a certain clinical acumen and understand how to use natural compounds, how to dose them, and how they interact obviously with other medications and so on and so forth. But that could be something that we explore too, because it's safer and we see that it's working and people are getting better. So that's another, thing that we need to explore as well, right? I mean, I'm a conventionally trained doctor. Of course, pharmaceuticals always play a role and so on and so forth. But I think this disease is so different and so massive that we have to think outside the box, like Resia was saying, and try to come up with other alternatives that are possibly safer and just as effective.
Wonderful. So yes, so Resia, we didn't even get into some of your slides, but don't worry. This is just stage one. This is so important that I think there are other researchers we want to pull in. Resia, you'll be central to that, and we will definitely continue the discussion. I just want you to think about it. Imagine those clots as I had shown you, how in the world and what could be done for the future. The important thing for listeners is to remember this. We are searching for answers. There are scientists across the world who are trying to find answers. And so Risia's work in South Africa, if there are scientists who are listening or people who should be supporting them financially, absolutely, because we need this kind of scientific input to come in. At least her work has started so that we have a framework for what to look for. And I think Professor Kell said this last night. It is so simple to check. Just put the amyloid stain and you will see straight away if this is amyloid fibrin microclots. So there's still a lot of work to do, but we've got the right people on it. Stay tuned with us for the future. We'll have more discussions around this. Thank you all very much.